Okay, hello everybody. Welcome to the Falls Lecture Series. This session is recorded, so if you don't want to be on YouTube, you need to switch your cameras off so that your video isn't on there. Make sure that your mics are muted, please. That would be great. Put any comments into the chat. But I will open up the floor to questions because I'm sure that you're going to have a lot of questions for Tony at the end. So Tony holds a senior physiotherapy position at the Falls Clinic at Sir Charles Gardner Osborne Park Care Group. His extensive knowledge and expertise in falls prevention, honed over many years, is widely recognised both here, across the state and nationally. Indeed, if Tony doesn't know about it in the field of falls, it's probably not worth knowing. Tony's remarkable contributions have not gone unnoticed. The WA Health Older Person Health Network has bestowed upon Tony a Lifetime Recognition Award. This honour is a testament to his impactful work in falls prevention across the state over the years. His dedication and his achievements truly deserve this recognition. So thank you, Tony, for everything that you've done. So I invite you all to sit back and enjoy this presentation by Tony. Thank you.
Thanks, Sue. Hello, everybody. I always say this, I hate presenting online, mainly because I like to try to really interact with the audience where possible. And when I'm usually in person, I can act like a goose and make you do things, but we'll do it this way because this is the way that technology is going. But the title of today's talk is really Falls and Frailty. And when I was getting it ready, I actually pondered, should it be frailty and falls? And then I thought, am I actually talking about the same thing? And after doing the talk, I'm still not decided whether falls and frailty or frailty and falls actually means exactly the same thing. Or maybe it should be frailty equal to falls, but I'll leave that for you to decide. So fact or fiction? Frailty is an inevitable rite of passage as we age. I can't see you or hear you, but I suspect you're all saying that that is absolutely false. And it is. The one thing that none of us should actually aim for is to become frail. Now, there are things beyond our control and there are things that we have the ability to influence. So certainly the aim is that we age as healthily as we can by adopting, healthy lifestyle principles as we age. So we exercise regularly, we adopt the best nutrition that we can, we sleep well, we have good social connections. There are other things, unfortunately, that we can't influence, like our genetics, which might predispose us to particular conditions, which might then impact our function as we get up or get older. I love this little image. This is a chap from quite a few years ago now, 7 or 8 years ago, who at 88 graduated from university. He managed to get his Bachelor of Science, I think, in Christian Sciences and things. But he lost the opportunity to study when he was a younger man, but went back at a much later age. And his colleagues in his course said he's smart as a whip. And I just love that. So thinking about how we age, when we're thinking about kind of like frailty, sometimes that terminology is believed to be a little bit negative. But so they often, the World Health Organization is almost moving to this concept of intrinsic capacity, which really relates to kind of like all of our physical and cognitive abilities that we have available to actually function successfully. And that is influenced by our environment, but it's considered to be, when we're looking at this diagram, almost consider that the environment is relatively stable. Our environment will include things such as our kind of like social network, as well as our physical environment. And what we can see is that, particularly with the green line, that we can age really healthily, and a lot of people do. But typically, the average, in essence, go down the usual pathway, so the red line. And for some, they have an accelerated aging. So they acquire, or they end up being frail at a much earlier time period. So you can see that the aim of aging well is to delay, if possible, the onset or of frailty for as long as possible. And hopefully maybe it only becomes really relevant for us at the very end of our life cycle. Picking something here. So the aim is to live healthier for longer.
Tony, you've muted yourself.
Hello, when did I mute myself? How long ago?
You said aim to live healthier for longer.
Right, I don't know how that happened because I wasn't touching my computer. But anyway, right. So we aim to live healthier for long, but essentially we want to delay the period of when we're living with our physical conditions and disease. So frailty is a dynamic state that is reversible, fact or fiction. So frailty is not really a mutually exclusive condition. So frailty is really a spectrum. Some measures of frailty tend to just describe frailty as you're frail or you're not frail. But the reality is many of the other scales tend to measure frailty along a range. The aim is for us to be robust and to be as robust for as long as we can. In between robust and frail, we have pre-frail, and then we have a spectrum of frailty before we get to disability. The key thing is that we actually are able to reverse frailty. But the further it progresses, the harder it is to reverse. So we think of frailty as this dynamic clinical state of reduced functional reserve, which increases our vulnerability to develop negative health-related events when exposed to an external stressor. So the best way to think of this is an individual, an older adult, for instance, who might come down with the flu. A frail older adult who comes down with the flu, it might take them a longer time to recover than a fit older adult who gets the flu and might be able to recover in a much quicker time. So the opposite to frailty is this concept of resilience, where we look at our ability to rebound well from these external stresses. And one of the things that's become really interesting in this area of frailty is the scientists looking at how we actually measure resilience. And that's one of the things which they're really kind of like trying to grapple with, how we measure resilience and whether we're measuring it just from a physical domain or are we measuring it from other psychological or social domains. Frailty is associated with many negative outcomes, and one of those is falls, which is a topic of today. And depending on the study and depending on the methods and tools used to measure frailty and the setting, the prevalence of frailty will vary. But generally, as we get older, the prevalence of frailty does increase, which impacts us who work in an aged care setting or with older adults. The other way of looking at our frailty to disability is really looking at it on a linear scale like this. And our aim is to keep everybody to the left of the disability threshold, which is the vertical line that we see in the middle. It is much harder to get people back from disability to frailty than it is to keep people on the left of the line and move them either from frailty to pre-frail, either keep them at pre-frail or keep them at a robust level. So early intervention, and preferably starting way back through adopting healthy principles when we're much younger, given that the onset of changes in our intrinsic capacity can actually occur almost 25 years before we get to the point of frailty, is really something which should motivate all of us to age well. It's much easier to do it and to prevent it from occurring than to try to manage it once it occurs. This diagram here really shows the kind of like the spectrum of frailty, both from a a functional level on the bottom. So if we look at it just from a mobility perspective, we can see very easily the changes that occur as people acquire frailty and then disability right on the right-hand side of the screen. But frailty really occurs, or this biological basis of frailty in essence occurs at an organ level, where it starts off with one system and that eventually involves multiple systems. And it means that our ability to bounce back when we have an illness or some stressor, and it doesn't necessarily need to be an illness, it could be the death of a loved one or some other stress event. It's interesting, I've had a couple of clients recently and there's been no change in their physical health at all. In fact, they've been functioning at quite a good level, caring for their partners who've been unwell, and they've nursed them for up to a year and then they've passed away. And within 2 or 3 months of their partner's passing, both have really had lots of functional problems and have not started to cope at home. It's almost their whole physical and kind of like their psychological abilities have really deteriorated, and that was just through the death of a loved one. So frailty can be impacted by many things. Some of the things which can lead to frailty includes things like malnutrition, which is believed to cause about 8 times the risk of developing frailty, physical inactivity, things like smoking and alcohol, genetics, which we don't often have a lot of influence over, issues like polypharmacy and psychosocial issues. Other things, for instance, like, low birth weight actually is associated with a higher risk of developing frailty down the track. Manual type labour can potentially lead to increased risk of frailty. So there's exposure to violence through midlife. So there's lots of different factors which, other than just biological kind of like factors and disease, which can influence the development of frailty. Related to frailty, and I just wanted to briefly mention, particularly when we relate it to falls, are the issues of sarcopenia or weak muscles and osteoporosis. Obviously, we want to prevent falls because we want to prevent any potential injury, of which obviously fractures are some of the most significant injuries. So people who fall on osteoporotic are obviously much more likely to fracture. Muscle weakness is closely related to bone strength, and it's also closely related to frailty. So sarcopenia is really the low muscle strength and muscle mass, particularly within the skeletal muscles, and that can obviously adversely impact our daily activities. So people who've got sarcopenia are at risk of developing frailty. Not all who have sarcopenia will have frailty, but there's a close association with it, and they share common risk factors. So we often think of weak muscles and weak bones as key things we're wanting to obviously address when we're thinking about falls prevention as well. This is not the time to talk about the different approaches to measuring frailty, because we could probably spend a couple of hours talking about it, other than to say there are many different approaches. There's no universal agreement on a standard tool. They take slightly different views. The frailty phenotype really focuses on frailty as a biological syndrome. The frailty index really looks at the accumulation of health deficits across multiple domains, and this is usually something which is very difficult to do at an individual level, but might be done at a system level, such as a electronic frailty index based on hospital coding when people come into hospital. And the other one which can work really, really well at a clinical level is frailty indicators, such as the Edmonton scale, for instance, which is a multi-dimensional approach to frailty, which is usually how I kind of like view frailty. And it looks at multiple domains as potentially or being impacted, not just physical and psychological, but also social aspects of human functioning. This is just an example of Fried's frailty phenotype. So it's very much based on looking at things like weight loss, muscle strength, slowness or walking speed, and then things like physical inactivity and exhaustion. And the presence of 3 or more factors of that will lead to a person being described as frail. But it is very much just frail. There's no mild frailty, very mild frailty, or very severe frailty. It's just frail with the Freed's frailty phenotype. The clinical frailty scale is also kind of like a measure of physical function, but it also focuses on things such as activities of daily living. It's a nice little system. It summarizes the outcome of a multidisciplinary assessment or a comprehensive geriatric assessment very nicely in terms of being able to grade the degree of frailty. And why this is quite nice is, in particular, is that it can also help to guide interventions, particularly even when you're thinking about, even things around falls prevention, is that what you might do with a faller who's living with severe frailty might be quite different than the strategies that you implement when you're addressing somebody who's living with very mild frailty. But I'll talk a little bit about that later on. Frailty is a risk factor for falls. You're probably thinking, well, yeah, it's pretty obvious that it is. Well, actually, the evidence is, even though it does seem pretty obvious when you kind of like think about it, given the shared kind of like risk factors between frailty and falls, when they actually look at some of the studies, it's not like there's 100% agreement or 100% association. It's actually a little bit conflicting. It's widely accepted, but it's likely that the methodological issues and studies are really the things which kind of like impact this. There was a large meta-analysis of over 1 million people in 2023, and that was based obviously on multiple studies. But what they found was that frailty was associated, or that 48% increased risk, but that was with all frailty tools. So they believe that certain tools, particularly ones which I think focused on more of some of the physical risk factors and stuff, were better predictors of falling than other tools. The other thing that came out in 2020 was one based on recurrent falls, where they actually looked at predicting frailty after 5 and 10 years. And what they found in this instance, that the actual presence of frailty was more predictive than having a prior fall. The general consensus is, regardless of what the studies show, is that given the clinical features of frailty, that it is a trigger for, or is really a risk factor for falls. And certainly in the World Falls Guidelines, which came out in 2022, it really was considered a trigger for pushing a faller into the high risk category for future falls, and so it leads them down a particular pathway of intervention. I like to put this slide up mainly when I was looking at this kind of like topic, and just to kind of like show that this was really the pattern of injuries, or the mechanism of injury really, for people experiencing a hospitalized fall or a fall at home and resulting in hospitalization. And one of the things that's really interesting, that as we age, falls from mobility related, so just typical walking related activities, tend to reduce over time. And the descriptions of other falls tends to increase. So we can kind of like assume that obviously people are doing less locomotor tasks as they get older. Not all, but on general. And then if we look at the next graph, what it shows is that basic functional tasks like these are like, or the proportion of falls with involving a bed and involving a chair. So fundamental tasks which are essential for people to be living at home successfully, the proportion of falls that occur during these activities increase as we get older, which reflects an increase in frailty. So I think that kind of like also guides us into the type of interventions that sometimes we need to manage for people who are further along the frailty spectrum. So we're thinking about frailty as being a factor in terms of causing falls, but is it actually just a one-way relationship? Well, actually, it's probably not. Falls and frailty are pretty closely linked, and that's fairly obvious, but the relationship is actually bidirectional. Not all fallers are frail, and not all frail people will fall. We have lots of people who are, you'd almost consider robust, and they actually fall. how they fall, the mechanism of fall would be quite different to somebody who is considered quite frail and might fall during a bed transfer or fall walking to the toilet at night. Falls, in essence, can also then result in frailty. It can be a vicious cycle in terms of somebody who's had some functional decline, or they fall, they might sustain a serious injury, or their fear of falling resulting as a result from that fall could be quite significant, cause people to curtail their activity, which makes them become more deconditioned, resulting in them developing some frailty, or more falls, which results in a vicious cycle. So it's not a very simple kind of like relationship to think that we're just, because we're frail, we're going to fall. It's important that we need to address both frailty and falls in terms of trying to manage these conditions. If we go back to the World Fall Guideline screening algorithm, so this is something which was published in 2022. This is kind of like guidance, or provides a nice algorithm in thinking about how we address people who present with a fall. So people who've had a fall in the past 12 months, we're usually wanting to know whether they have had a fall or not had a fall. If they have had a fall, one of the things that we use to assess fall severity is looking at whether they've had any injuries, whether they've been a recurrent faller. But one of the things you see there right there in the middle is frailty. So this is automatically like a trigger which guides us into thinking we need to do a more comprehensive evaluation of this client. And there's other things there like lying on the floor and loss of consciousness, suspected syncope. So we can see that frailty really guides us into doing a more comprehensive assessment of that client. So in the World Fall Guidelines, there are a few things where they mention frailty. Firstly, that falls in the presence of frailty is really like a warning sign of unidentified pathology. And it might be that when we assess a person with a fall, we don't really necessarily know whether they're frail or not at that time. Sarcopenia is also commonly associated with frailty, as we said before, but there's also a much higher risk of falls on follow-up at 2 years in a study of the over 80. And this was done a number of years ago. Gait velocity, they mentioned that gait velocity is a really important, it's an important measure in falls risk, but it's also an important measure in frailty. And they're wondering, could gait velocity be some kind of measure of both frailty and falls risk rather than considering them as two separate entities? Another thing which they mention is, and I don't do this as a test myself, but I do often assess floor transfers, is they describe that the use of a floor transfer test where asking an older adult, for instance, to see whether they can actually transfer up from the ground and if they can do it within 8.8 seconds. This was originally done actually for stroke people, but they give that value of 8.8 seconds as a good indicator of physical function. I certainly don't time it for my clients because I think it's more important whether they can actually get up. It doesn't necessarily matter whether they can do it in 10 seconds or a minute, as long as they can do it safely from my perspective. It becomes more of an issue if they can't get up after a couple of minutes because we know that they're more at risk of having a long lie. And the other issue around frailty is that around medication review, and that we must, particularly when a medication review is being conducted and the deprescribing of falls risk drugs, that the impact of frailty is really considered on this. The other thing that they do mention, despite all this, is that what we don't know is that if we manage frailty, how does that actually impact falls risk? There actually still isn't conclusive evidence around that. So just a quick word on gait screening is for those of us who are involved in the physical assessment of people at risk of falls or frailty, we do need to get into the habit of measuring gait velocity. It's a very simple test, simple walking test that we do over the course of about 8 meters. And what we see is that many of the measures are fairly consistent. So gait speed less than 0.8 meters per second, or probably a more easier term to gauge is 48 meters per minute, is the same as the measure used for measuring sarcopenia. There's slight differences in the measures for frailty, but partly that's because with Freed's frailty, they actually do a correction for height of individuals. So the taller individuals, we can see 0.76 is very close to 0.8 if you think of rounding. But So it's quite feasible that down a track, they might come up with some kind of like value of gate velocity, which can be used as a proxy for all three of these very common conditions. So trying to kind of like tie it all in together. So frailty is a falls risk. Frailty is really multidimensional. There are definite physical kind of like dimensions of frailty. So if we have a look at some of the physical characteristics that we see in the frail person, these are things which we also see in a person at risk of falls. They have balance problems very often. They're unsteady with their walking. They might have sensory impairment, so they can't sense the environment to help them balance very well. Strength is an issue, and fatigue during daily activities means that we're more likely to see falls because we can't sustain an activity long enough. Then we have the psychological dimension, which is really almost thinking about our cognition and our decision making. We know that physical frailty can be associated with this concept of cognitive frailty, where there are subtle changes in our memory and thinking or our executive functioning, but not at the threshold of actually being able to have a diagnosis of a dementia, for instance. And then we've got the social factors, people living alone, no support. All of these are really important when it comes to actually thinking about falls. One of the physical things that we like to think about is related to blood pressure. So we know that unexplained or recurrent falls often have a cardiovascular cause, and we often think, and the most common of those would be orthostatic hypertension or postural hypertension, where there's a drop in blood pressure on standing. What we do know with frailty is that we can easily have impaired physiological responses. Standing up is actually quite a challenge. There's a lot going on. Our blood pressure needs to adjust. We need to acquire our actual standing balance, need to orientate ourselves. So it can represent quite a significant challenge. The World Falls Guidelines tell us that we need to measure blood pressure as part of a comprehensive falls evaluation. There's been a number of studies which have looked at falls and frailty and orthostatic hypertension. So there was one in residential aged care which showed that there was an association, orthostatic hypertension was associated with both falls and frailty. And in a large Irish study, they didn't really look at falls per se as an outcome, but what they looked at was at orthostatic hypertension and seeing whether it was associated with frailty markers. And what was really interesting with this study, and probably what's really important to take away, there wasn't actually just orthostatic hypertension. In fact, it was actually orthostatic intolerance. So being symptomatic on standing without actually having an objective reduction in blood pressure that was more commonly associated with markers of frailty. So from our perspective, when we're doing a falls assessment, we do need to measure postural blood pressure. And obviously also importantly, listen for symptoms, even for people who are maybe don't have a postural drop, like an objective postural drop in terms of they're both systolic or diastolic. But if they're symptomatic in standing, that may well be an underlying marker or suggestion that there is actually something going on with their health that we need to investigate further. In terms of falls, staying upright requires careful decision-making to perform tasks. That decision-making comes not just from our physical capacity, but it actually comes from our cognitive capacity. So there's this concept of cognitive frailty, as we mentioned briefly before, where there's a reduction, or where physical frailty and mild cognitive impairment coexist, and there's a reduction in our neuropsychological reserve. Really, the best way to be thinking about this is that if we're a little bit physically impaired and there's a close association between physical changes and cognitive changes, that we need greater cognitive resources to maintain an upright posture and ambulate safely. And then when our balance is challenged, we may not necessarily have the ability to respond appropriately enough because we can't allocate attention to staying safe. So we need to be thinking about more when we're seeing our patients who are frail, that they might really struggle a little bit more with more complex tasks. So we need to make sure if we're providing rehabilitation or education in this context, that we try to address, those daily activities where people are, for instance, dual tasking or multitasking. The final thing which I just like to mention with regards to the kind of like the risk factors here is really around that social aspect to falls and frailty. And this is something which comes up all the time because we're always thinking, how can we get services and supports for our clients who are socially isolated and vulnerable? Working within the public health system, I've seen so many people who are always isolated. They don't have any family who are in regular contact. So we know that being socially vulnerable is associated with worsening frailty, and people who are socially vulnerable often live alone. And we know that those who live alone, if they have a fall, they're at long risk of a bigger risk of a long lie, which is associated with a worse outcome. So these people who are socially vulnerable or isolated, can't get services and supports and don't know where to go, we really need to work very hard on trying to actually work out, particularly from a falls prevention perspective, how they're going to be safe at home in the event of a fall. Anecdotal story from a gentleman who recently widowed, who I saw 2 weeks ago. He came into clinic for an assessment, and I was talking about this because he didn't really have a lot of social connections. The only one that he had was a cafe owner who he went to every day after lunch for a couple of hours. And he said, I'll quite happily take some information on personal falls alarms, Tony. And then when I went to see him again, he goes, you wouldn't believe it, but my friend actually called me that day after I came into clinic because I didn't get to the cafe, to actually say, where were you? And I said, well, there's your mechanism in terms of one of your falls action plans, is that you can rely on your friend, and you need to try to have a chat to him about formalizing that kind of like relationship and agreement, that if he doesn't hear from you, if he can give you a call to find out, then that's a really good safety mechanism in practice. So what does frailty status mean for falls prevention? Now, this is not kind of like gospel. It's just what I was trying to kind of like think in terms of summarizing it. But if frailty is present and a person's had a fall, they automatically go down that high risk pathway for falls risk assessment. So we really need to do a multifactorial falls assessment and customise the treatment plan. And this is through either comprehensive geriatric assessment, multidisciplinary care, whether that's occurring within an outpatient setting or a primary care setting. And the frailty status can assist in guiding intervention strategies. What about if you're frail or pre-frail, but you're not falling? Well, there's something's going on there which is protective, which is great. But what we want to do is we want to prevent progression of frailty or progressing people going to frailty, but we still want to address falls risk factors. So that might be making sure that we encourage people to adopt healthy lifestyle principles. We look at the interventions which can be used in managing frailty, which are very much around comprehensive geriatric assessment, nutrition and exercise, social connections and lifestyle factors. If you're robust and not falling, again, what are they doing well to stay robust, and really reinforcing again those healthy aging strategies of, progressive resistance exercise, good diet, good lifestyle, as well as providing falls prevention education to them so that they're aware that falls might be a risk in the future and what they can proactively do to stay safe. So the kind of like the guidelines tend to, if we go back to the guidelines here, that column on the left will take the majority of people who are frail and having had a fall. In regards to frailty, the evidence is emerging, but it's still inconclusive about how we can prevent frailty perfectly. We haven't got like the perfect answer yet, but what we do know is there are some strategies which can work. Firstly, we need to realise that frailty is complex and no single intervention will suit all patients. But it can be reversed, and the earlier we intervene, the better. So a comprehensive geriatric assessment is one approach targeting all of those risk factors that people have, or the findings of frailty, such as sarcopenia, weight loss, exhaustion, and actually trying to see if anything within those conditions is reversible and addressing it from a medical basis. But there are other factors which are really important. And in fact, the most important factor in terms of both the prevention and management of frailty is around exercise and nutritional support, without question. Exercise is actually believed to be almost like the gold standard thing. It's better than any drugs at the moment, from what we know, in terms of treatment. But the issue is that it needs to be sustained and almost lifelong. If we stop exercising, then really we lose many of the benefits. Other things around lifestyle modification, good medication management, building resilience, which is one of the big things which I think is going to be something in the future in terms of how we do that, but also actually thinking about advanced care planning and end-of-life care. And that many of our frail patients who we see are right down the, are approaching that end-of-life period. And that good care for them is also about actually planning for that end-of-life period, and not actually providing interventions which might not actually be in their best interests, and maybe not to what they actually want to do. We always need to remember that it needs to be goal-driven by the patient. We need to listen to our clients. So this cascade of functional decline shows that what we need to do is we need to intervene earlier. So every time that there is a stressor, people can progress down that spectrum. So if we can keep people at either, particularly if people are at pre-frailty, if we can keep them there, we're going to really try to actually, be able to maintain them at a much better level and prevent the onset of disability rather than people getting to that frailty stage. It's very hard to go from disability to frailty. Who is our client? So from a frailty perspective, is all of our clients might benefit from some kind of like physical intervention. The lady on the left, but she might just be, we just might need to give her more guidance around keeping strong at the gym and the importance of progressive resistance training, which is targeting both muscle and bone, and a good diet. Our client at the bottom left-hand corner, who is dependent on his carer for mobility and transfers, but still has a fall, our targeting might be around how we safely manage that client at home and provide carer support, as well as addressing any medical conditions which might optimize that individual's kind of like well-being during that final period of his life. And our lady up the top here in the middle with her walker, how can we keep her strong enough and mobile enough to keep accessing the community safely? This is just something which comes out of the British Osteoporotic Society, and I just put this up just if there's any physios out there and thinking about our frail, falling, sarcopenic patient who've also at risk of fractures, and thinking, where the hell do we start with them in terms of actually doing some rehab? The key thing with this is why I like it, is that if you're frail, falling or unsteady, which is a lot of our clients, we need to make sure that we prioritize them being safe on their feet and steady first. And from there, we can then progress to being able to implement a much more much more strengthening exercises down the track. But we start at keeping them safe first, and then we progress there. So that's just like a very simple little guide, just in terms of thinking, well, where do I start? Well, we make sure that we're safe. If we look at the evidence which comes from the recommendation of older adults or exercise in older adults, they often categorize it in terms of particular conditions, but the reality is that these conditions overlap. So the frail, sarcopenic, and person who's falling, the exercise interventions are very similar. So I suppose we can take confidence is that if we structure a program well, we can address both or many of the kind of like coexisting clinical conditions or syndromes that we see in our clients. So if we're summarising it, looking at resistance and balance exercise 2 to 3 times a week. But the other key thing with this is the importance of nutrition. And some of the key things around nutrition are around things like vitamin D, protein intake, and even though the recommendation from a lot of the work and a lot of the stuff presented at the recent Frailty and Sarcopenia conference was that protein intake of at least 1.2 grams per kilo per day for healthy older adults was really the key, and generally above the normal RDI protein intake of 0.8 grams per day, calcium intake and creatine, and that nutrition alone, in the absence of exercise, the evidence around that is inconclusive. But together, they play a really vital and powerful tool in terms of trying to address frailty. One of the key things around nutrition or nutritional supplementation is that it's very important to address and prevent malnutrition. Firstly, because there's an increased risk of frailty, but it can also blunt the exercise responses from a rehab perspective. It is critical and crucial to try to get dietitian review as early on, I think, in terms of our frail clients. We want to optimize the quality and quantity of nutrients that these people get through their diet, and also have our dietitians and stuff be able to provide the expert advice if they need specific nutrients. One of the things that they mentioned in this recent conference I went to was disuse events where, for instance, which they align to like acute admission, where somebody comes into hospital for like a flu, an older adult comes into hospital for a flu and is bedbound for 2 weeks. That can almost be like a 2 years of aging. And so it's really vital during that period that not only are we doing physical rehabilitation with those clients at the, after they've recovered from the acute event, but we really optimize their nutrition during that period to really prevent some of those adverse skeletal muscle changes which occur. Making sure that we identify barriers to effective nutrition, and also, like, again, just thinking about it from a hospital perspective, is that we're providing good nutrition when they're in hospital, but people can't feed themselves and nobody's helping to feed them at mealtime, well, then it's almost pointless. So making sure that people can actually get the food in and that we're providing adequate support at a ward level to be able to do that. So finishing off, falls and frailty have a close bidirectional relationship. It's sort of like cause and effect, but I think it's a bit difficult to untwine. Frailty is multidimensional, and just as falls are multifactorial. So it's a very complex relationship. I think when both are present, it's really important to address them together rather than thinking too much about separating them out. There are some specific risk factors for each, but we really need to address what we find in our clients, and that the frailty spectrum might be able to provide some guidance for us in terms of what interventions are most appropriate to use. Comprehensive geriatric assessment is one of the key elements of this. And if you don't have the opportunity, if you don't work in that team, making sure that you involve your professional colleagues from different professions, because a multifaceted approach will often work best. And one of the things which is mentioned is about exercise across the lifespan being medicine. And that's one of the key things I think that we really need to encourage from a much younger age. Okay, thank you.
Thank you very much, Tony. That was a brilliant presentation. Really appreciated. I'm just going to stop the recording and then we'll open the floor up to questions. Just hold on.